Hey guys, this one should be short. This is a brief overview basically of the physiology of how blood is oxygenated and how we perfuse our bodies. Here's your objectives. Only 2. See, I told you it would be short. Now you got a nice picture of a part of your lung. The little sacs at the bottom are the alveoli. So the alveoli is where oxygenated venous blood, no, that's not right. The alveoli is basically where the exchange takes place in the body to pass through oxygenated blood and remove carbon dioxide from the blood. So you have to have properly functioning cardiovascular and hematologic systems in order for that to happen. When I say hematologic, I really kind of mean mostly plasma and your hemoglobin and hematocrit. Remember, hemoglobin and hematocrit, and actually plasma as well, carry oxygen. So this carries nutrients and waste to and from body cells. Respiratory function. I need you to understand, not so much map, because I feel like that's in future blocks. I'm not sure why it is bolded on here. It's a good thing to know, and we'll talk about it, but really you need to understand perfusion versus respiration. So these are the functions of the respiratory system. Pulmonary ventilation is the movement of air into and out of the lungs, inspiration and expiration. So what do you need to have good inspiration and expiration? You need to have a decent pair of lungs that are elastic so that you can take in deep breaths and then you can let them go. So if you have weak lungs or a weak musculoskeletal system, you may have poor ventilation. So there's a lot of different things that can affect how well your body is getting oxygenated. So from the respiratory perspective, this is one of the things that will affect it. So that is ventilation, simply movement of air into and out of the lungs. Inspiration is the active phase. You are physically taking in that breath. It's the process by which all living organisms take in oxygen and give out carbon dioxide to release energy. That's respiration. So respiration, know that definition. It's taking in oxygen and giving out carbon dioxide to release energy. So respiration is a major and vital process of gas exchange. The transport of gases during respiration, both oxygen and carbon dioxide, are carried out by the blood cells. It's important to remember that the respiratory system has functions that are not directly related to gas exchange. The respiratory system's functions are, I would know all of these things, oxygen and carbon dioxide exchange from the bloodstream, vocalization, abdominal pressure regulation. So think about compression during urination or micturition, passing of feces or defecation, and childbirth. So that's your ability to bear down. That's that abdominal pressure regulation. That is assisted by the respiratory system. And it's a protective mechanism, coughing and sneezing to keep the passages clear. So those are some different things. Perfusion, which that is the process by which oxygenated capillary blood passes through body tissues. So perfusion. You know how I'm always talking to you guys about how you can have pain in your body, and that pain could be due to lack of perfusion. So perfusion is, do you have the blood? Do you have the pressure? Do you have everything you need to get the oxygen to the capillaries to pass through the body tissues? If you look at this example up here that is in bold, The way we figure out if you have enough perfusion is we look at the MAP. So there's the formula for MAP. You don't need to know that in block 1, but it's a good thing to know anyway. Systolic blood pressure, so your top number in your blood pressure reading, plus 2 times your diastolic. And then you take that total and divide it by 3. So if you look at this example, you have a blood pressure with a systolic of 78 over 50 diastolic. What is the MAP? So you take 78 plus 2 times your diastolic, which is 100, and divide it by 3, and that equals 59. And I will tell you that 59 is not a good number, and you're not perfusing your organs and tissues with a MAP of 59. And I think you can probably tell why. Look at that blood pressure. If you are at the hospital or even in the long-term care settings, when you're taking the blood pressure with the automated cart that you're pulling around with you, oftentimes it will tell you the MAP, and that number is in parentheses right underneath the blood pressure. So you can easily just look up and see if their MAP is enough to perfuse their tissues. And we're looking for a minimum number of 65 for that. Gas exchange or respiration refers to the intake of oxygen and the release of carbon dioxide. And we do that by respiration and perfusion. So we need both respiration and perfusion for gas exchange to occur. And it does occur via diffusion. And the purpose of the respiratory system, or one of the main purposes, is to perform gas exchange. Pulmonary ventilation provides air to the alveoli for this gas exchange process. So when you pull in that inspiration, you're pulling in air. At the respiratory membrane, where the alveolar and capillary walls meet, gases move across the membranes, with oxygen entering the bloodstream and carbon dioxide exiting. So picture someone who has fluid buildup in the lungs, and it is going to pool down at the bases, which guess what? That's where the alveoli are. Do you think they might have a hard time performing gas exchange? Or someone that has COPD and their alveoli are damaged, or someone that has pneumonia and they have fluid or mucus in their lungs. Anything that prevents that oxygen from getting to that bottom of the lungs where the alveoli are and the capillary walls, that is going to impact the ability to do the gas exchange. So your bloodstream carries the waste from the carbon dioxide back to the lungs, and then it's removed from the bloodstream and exhaled. Your lungs and your respiratory system automatically perform this process as long as they're working. So in order for perfusion to occur, we have to have enough blood and we have to have enough blood pressure. Breathing is a mechanism, or it's a mechanical process where the air volume changes in the chest cavity. So respiration is a biochemical process where oxygen is introduced into the bloodstream and carbon dioxide is expelled from the body. The transport of oxygen and carbon dioxide in the gas phase from the ambient environment to and from the alveolar gas/blood interface is accomplished through the tracheobronchial tree and involves diffusion. During respiration, about 97% of oxygen is transported by red blood cells in the blood. Hemoglobin being the pigment present in the red blood cells that gives blood its red color. About 20 to 25% of carbon dioxide is carried by hemoglobin as carbaminohemoglobin. 7% is in a dissolved state in the plasma and the remaining is carried as bicarbonate. So perfusion, see how that's in red? Probably should know that. Perfusion, diffusion, respiration, ventilation. Know what those are, because you might get a question wrong on the test if you're not thoroughly familiar with what does what and what does it mean. So perfusion is a process by which oxygenated blood passes through body tissues. And remember I said you have to have enough blood and enough pressure to make that happen. All right, next slide. Here's a great little example where we're going to use our clinical judgment model to look at a patient's scenario. So you get report on your patient, you're just coming on shift. They came in with a GI bleed. So they're bleeding somewhere in their gastrointestinal system. You go into the room and the patient is lethargic and they can only tell you their name and where they are. They're not able to say their birthday or who the president is, none of that. So you get a set of vitals just to see what's going on, and you get those vitals. So what do you think is going on? Why are they looking like this? So if you're recognizing cues, what does it say is going on with the patient? It says they have a GI bleed. So if they have a GI bleed and their blood pressure is low, and I already gave you the example earlier that 78/50 had a MAP of 55, I believe. We already know that's not enough to perfuse our organs and our tissues at the capillary level where it exchanges with all of the organs and the brain even. Their heart rate's 125. Why do you think that is? It's because the heart is compensating because the pressure is low. It's trying to pump it faster. And their respiratory rate is 20. Also high end of normal, but it's compensation. Their oxygen saturation is 89%. So recognizing cues, they have a GI bleed, their blood pressure is low, their oxygen saturation is also low, their heart rate and their respiratory rate are trying to compensate. We're going to recognize that they're probably losing too much blood, so they don't have the volume to perfuse. I just went through recognize cues, analyze cues, and prioritize. Our hypothesis is that bleed is causing them to bleed out. So what are we going to do about it? Generate solutions. Oopsie, sorry, I went a little crazy there. I'm going to say that I'm going to call a rapid. Why not? Because those are not good sats. I want respiratory to come. Because we might need to intubate. That's going to call the doctor. It's going to get transport there because if we intubate, they're going off to ICU. But my first thing I want to do, I want to put oxygen on them, and I want to get an order to give a bolus of fluids. So why do I want to give them fluids? I want to give them fluids because they don't have enough volume to keep their pressures up because they're bleeding out. So the first thing I can do is dump some fluids into them. Then, I've got to get the doctor on the phone for that, or they have to come to my rapid. They're going to probably do a type and cross, which is going to tell us their blood type. And we're going to get a stat order for some blood so that we can get some new blood into them. And maybe once they're stabilized, we're going to send them off to find out where that GI bleed is and take care of it so that it doesn't continue to happen. So fix the root cause. So in poor perfusion, in that example we just did, the CNS is affected. We already kind of said why. It's because the brain is not getting the blood flow that it needs to function. Already talked about all that. Thus why this is going to be a short little video. The cardiovascular system works together with respiratory. So a lot of times we have to do differentials to see, is this going to be respiratory or cardiovascular? So we have to anticipate and look at signs and symptoms and work together with the physician. So the cardiovascular system is vital for the exchange of gases, and it's made up of the heart and the blood vessels in the body. We know that the heart has 4 chambers. The 2 upper chambers are called the atria, and they receive blood from the veins, which the bigger ones are the superior and inferior vena cava, and the left and right pulmonary veins. The lower chambers are called the ventricles, and they force blood out of the heart through the arteries, the left and right pulmonary arteries and the aorta. So the left ventricle is the larger of the two, and that is because the left ventricle is the pump that pushes the blood out of the heart to the body. So it has to have more muscular force behind it. The heart is the main organ of circulation, and oxygen is carried predominantly via red blood cells, binding between the hemoglobin and red blood cells and oxygen. It also carries, the hemoglobin also carries carbon dioxide. And then the electrical impulses control contraction of the heart muscles. So the sinoatrial node, or the SA node, the atrioventricular node, or the AV node, and the bundle of his atrioventricular bundle. I think that's enough about that. Next one. Alterations in the cardiovascular system can be due to many factors, including dysrhythmias or arrhythmias, myocardial ischemia, which is where you have cardiovascular disease in the major arteries that are part of the heart, so they're not getting the blood flow that they need. So you have ischemia, and ischemia is where you are not getting adequate perfusion. Stable and unstable angina or angina. I say angina. Belinda says angina. Either one is fine. Myocardial infarction, which is a heart attack, and heart failure. Most of what we talk about in block 1 is going to be angina and heart failure. A cardiac dysrhythmia, also called arrhythmia, is an abnormal or irregular heartbeat. So that's a problem with typically your electrical system. So an abnormal heart rate means your heart rate is either too fast. So remember, what is it called when your heart's beating over 100 times a minute? Tachycardia. Or it's too slow, typically under 60 beats a minute, and that's called bradycardia. But keep in mind, some athletes will have a low heart rate because they're in such great physical condition. Their heart is super strong, and it doesn't need it to beat fast. It's just going to take care of business without it being over 60 beats a minute. But a normal heart rate is 60 to 100 beats per minute. So an irregular heartbeat means that your heart's rhythm is disrupted in some way. So the electrical signal that controls your heartbeat might be interrupted due to scar tissue in the heart, or the electrical signal might start too soon and give you the feeling of your heart skipping a beat. In that case, you'll notice a stronger heartbeat right after the brief pause. Myocardial ischemia occurs when blood flow to your heart is reduced, which is kind of what I was saying. It has to do with the vessels being occluded. So it prevents the heart muscle from receiving enough oxygen. The reduced oxygen blood flow is usually the result of a partial or complete blockage of the heart's arteries, called the coronary arteries. We also call this coronary artery disease. A sudden severe blockage of one of the heart's arteries can lead to a heart attack or a myocardial infarction. Myocardial ischemia might also cause serious abnormal heart rhythms. Angina is a type of chest pain that's caused by the reduced blood flow to the heart. Angina is a symptom of coronary artery disease. The type of angina depends on the cause and whether rest or medication relieves symptoms. So stable angina is the most common form that you'll see out there. It usually happens during exertion. So you have chest pain during exertion, and then that pain goes away with rest or with angina medication. So angina medication, that would be like your nitroglycerin. So if somebody's diagnosed with angina, they're carrying around their nitroglycerin tablets with them typically. So pain that comes on when the patient is walking uphill or in cold weather might be angina. Stable angina pain is predictable, and it's usually similar to previous episodes of chest pain. The chest pain typically lasts a short time, maybe like 5 minutes or less. Unstable angina is a medical emergency. It is unpredictable, and it occurs at rest. I would know the differentiators there. Stable versus unstable angina. Which one is stable? Which one is not? Stable angina tells you right there that one's more stable. Unstable is chest discomfort or pain caused by an insufficient flow of blood and oxygen to the heart. If the blood flow doesn't improve, the heart is starved of oxygen and a heart attack can occur. Unstable angina is dangerous and it requires emergency treatment. Myocardial infarction, also known as heart attack, is caused by decreased or complete cessation of blood flow to a portion of the myocardium. Myocardial infarction may be silent and go undetected, or it could be a catastrophic event leading to hemodynamic deterioration and sudden death. Most myocardial infarctions are due to underlying coronary artery disease, the leading cause of death in the United States. With coronary artery occlusion, the myocardium is deprived of oxygen. Prolonged deprivation of oxygen supply to the myocardium can lead to myocardial cell death and necrosis. So basically, you're killing your heart muscle. Time is muscle. Heart failure, also known as congestive heart failure, is a condition that develops when the heart doesn't pump enough blood for the body's needs. This can happen if the heart can't fill up with enough blood. It can also happen when the heart is too weak to pump properly. The term heart failure does not mean that the heart has stopped. Most often, heart failure is caused by another medical condition that damages your heart. This can include coronary heart disease, heart inflammation, high blood pressure, cardiomyopathy. Cardiomyopathy is cardiomyopathy. Heart, MYO, is muscle. Pathy is disease. So disease of the muscle of the heart. Or an irregular heartbeat can also do that. Heart failure can damage your liver or kidneys. Other conditions it can lead to include pulmonary hypertension or other heart conditions such as an irregular heart rhythm, heart valve disease, and sudden cardiac arrest. Remember to look at the boxes and review the focus on the older adult sections of your book to ensure you understand how age affects each organ functional decline. Factors affecting cardiopulmonary function and oxygenation include the patient's current level of health, developmental considerations, medication considerations, lifestyle considerations, environmental considerations, and also the patient's psychosocial health considerations. As the patient's personal fitness improves, their body becomes more efficient at getting oxygen into the bloodstream and transporting it to the working muscles. As we age, important changes occur in the cardiovascular system. With advancing age, even in healthy individuals, that can include thickening and stiffening of the large arteries, and it happens because collagen and calcium deposit. And we also have a loss of elastic fibers in the medial layer, which results in systolic blood pressure rises. Diastolic blood pressure generally goes down after the 6th decade. In the left ventricle, modest concentric wall thickening occurs due to cellular hypertrophy, so enlargement of the cells of the left ventricle. Remember, if you start to experience all those other things I just said, that left ventricle is going to get larger because it's a muscle and it has to work harder to pump the blood out to the body. In the arterial system, the large arteries have thickening, dilation, hypertrophy, extracellular matrix accumulation, calcium deposits, and stiffness. Medications can also affect the cardiopulmonary function and oxygenation. These can include sulfa drugs, which is an antibiotic, nitrofurantoin, I can't say that. Heart medications like amiodarone, which is a medication to help your heart contract stronger. Chemotherapy drugs. I can't pronounce any of them except for methotrexate, but think about it. Chemo kills good cells and bad cells. Your heart has cells in it. street drugs. So people that are taking meth or cocaine or speed or fentanyl, whatever they're taking. Also, some medication side effects lead to new lung problems or worsen pre-existing lung disease. And some people are at higher risk than others. So people who have pre-existing lung disease, a history of smoking, those taking chemo, or those with a circulatory system illness. Studies have linked particle pollution exposure to a variety of respiratory and cardiovascular health effects, including inflammation of the airways and inflammation of the lung. Asthma, COPD, occupational exposure to unsafe chemicals, dust, fibers, frequent exposure to secondhand smoke, lung cancer, etc. So you can look right there and see that we probably could focus our efforts on helping with some healthcare disparities and outcomes for people that live in big cities. If you live near the airport, I've said this before, the air quality is terrible. So do you think that perhaps people that live around the airports in large cities may have more asthma, COPD, exposure to unsafe chemicals, dust, fibers, etc., etc.? If you think that, you would be right. Psychological health can also impact a patient's cardiopulmonary functioning and oxygenation. Stress and strong emotions can present with respiratory symptoms like shortness of breath and rapid breathing. For many, the physical symptoms of breathlessness are exacerbated by anxiety and panic in a vicious cycle of escalating breathlessness, physiological arousal of the sympathetic nervous system, and further panic. Conversely, scientific studies have shown that controlling one's breathing can help to manage stress and stress-related conditions. Breath control is also used in practices like yoga, tai chi, and some forms of meditation. On this slide, we have some of the diagnostic tests that we do to check for cardiopulmonary functioning. And it's how we differentiate, is this lungs, is it heart, or is it both? So cardiac coronary catheterization. I'm sure you guys have heard time is muscle. I said it a couple slides ago, but you've probably heard it other places. So if you suspect someone is having a cardiac event, do not try to drive them to the hospital. Call 911 because they can start the resuscitative efforts on the way to the hospital, as well as do the 12-lead EKG, start an IV, get all that done. So you're losing time if you take someone to the hospital in a vehicle, a personal vehicle. So once we get someone in the door at the hospital and we suspect that they're having a heart attack, we can do the 12-lead, identify their heart rhythm, give them aspirin, give them morphine, and sometimes nitroglycerin. And then we send them off to the cardiac coronary catheterization lab, or the cath lab, where we inject their arteries with dye, and we go in through an artery. Sometimes it's a radial artery, sometimes it's a femoral artery. We go in and we look, we take the scope, we look, and we find where the blockages are, and we deploy a stent or multiple stents if needed. If we're unable to successfully complete that cardiac catheterization, that's where the patient then has to have open heart surgery at times to reroute they'll harvest a vein from the leg and turn it into like a bypass of an artery. Thus, it's called a bypass. So you've heard double bypass, triple bypass, quadruple bypass, whatever it is. That's how many bypasses they had to do because the arteries were occluded or completely blocked. We can also look at cardiac exercise stress testing. It says exercise stress testing, but if somebody is unable to get on the treadmill and do that exercise test, then we also have medications that can artificially simulate that the patient is exercising and put stress on the heart, and we can see what the heart does when it's under stress while you're being monitored. And then we have the echocardiogram, which is an ultrasound of the heart, and we can look at the chambers and the valves in the heart, and we can watch the blood as it is entering and leaving the heart to see if there's anything structural going on that is causing an issue. So a lot of times you might hear someone talking about people in heart failure having a low ejection fraction. Ejection fraction is the percentage of blood that is being pumped out of that left ventricle to the rest of the body. And we expect that ejection fraction, so that is the amount of blood ejected out of that left ventricle, we expect it to be 60 to 65% in a normal, healthy heart. So if you hear someone has end-stage heart failure and their EF is 10%, that's what they're referring to. Their ejection fraction percentage is 10%. And so only 10% of their blood in their heart is being pumped out of that left ventricle every time it contracts. Well, that's not 65%. Do you think they have good perfusion? Do you think their blood pressure is awesome? If you don't think so, that would be correct. And then the other different methods, there are radiography, that's just doing some x-rays. Skin tests, honestly, I'm not even sure what that is. Lung scan, that's to rule out if the problem is the lungs. Holter monitors, that's a monitor that you can wear. Sometimes you wear it for 3 days, sometimes it's longer, where the doctors or the cardiologists can see what's going on with your heart on a normal basis. You can actually, on a lot of them, push a button and it'll send a message for them to like record what's happening right now. So maybe you're feeling some little episode come on and that's why you have the heart monitor on. You push a button. And then we have endoscopic studies, which is taking the endoscope and going in to look to see what's going on inside the arteries and the veins. Next. CPR. This is probably the only time that we have CBA instead of ABC. Or maybe it's CAB. If we suspect that someone is in cardiac arrest, so they're not breathing, they have no pulse, first we're going to check the pulse. Don't take a long time to do that, 5 to 10 seconds. If they have no pulse, initiate chest compressions immediately. And do not take longer than 10 seconds off the chest during cardiopulmonary resuscitation. And that, because they found that circulation is what tends to help a person recover more than breathing even. So we also want to make sure they have an airway. So tilt the head and lift the chin up. Check for breathing. The respiratory tract must be open so that air can enter. And then breathing. If the victim does not start to breathe spontaneously after the airway is open, give 2 breaths, lasting 1 second each. And defibrillation. That is where we apply the AED. And we use it as soon as we can. So we want it on there. The pads go on the front and back of the chest. And we turn it on and it'll tell us if we have a shockable rhythm. So every couple of minutes, if you have multiple people, you're rotating roles. So someone's doing the airway, someone's doing chest compressions, someone else has got the defibrillator. They'll say clear, and then the defibrillator will check the rhythm and they'll say continue compressions. That means this is not a shockable rhythm. So we cannot shock asystole, which is flatline. We can shock VTach and VFib, pretty much your ventricular rhythms. And we do that so that we can restore spontaneous cardiopulmonary work functioning. So we shock them and hope to get them back into normal sinus rhythm. This is the end of the chapter on cardiac perfusion.